Hi, it's a real pleasure to be here. I'm Matt Menard. I'm going to speak today on how creative do we have to be before we open. Is surgery a lost art? This is my disclosure. I'm going to start with a little bit of history. AAAs were first described in the 1500s by Vesalius. The first attempt at repair was by Sir Astley Cooper in 1817. It didn't work out so well. The patient died in relatively short order. Then began a long era of what I call the kitchen sink approach, where pretty much everything or anything in hand was used to put into the sac in an effort to obliterate it. The first successful repair was an aortic ligation by Rudy Mattis in 1923. In the 30s to 50s, we had wiring, we had wrapping, we had constriction. The first major advance came in 1951. Dr. DeBost performed the first homograft repair, and a modern era really began in earnest in 1954 with Dr. DeBakey when he used the first date-grind graft. This is a report of Dr. Creech and Javid's technique in 1966, and I can tell you that we pretty much do it exactly the same. A truly transformative moment that everyone in this audience would agree, 1991, Juan Perotti and his first use of an EVAR. And the obvious reasons in the wake of that some people consider or think this is what open is all about, a morbid and moral procedure. But what is the current status? Well, there's no question it was a seminal technological advance, and that's the reason that 80 to 90% of folks in the US get their aneurysm fixed in this fashion. However, there are some real concerns, and the early mortality benefit we know goes away in 5 years, and questions about durability persist, and in particular, rates of reintervention and late rupture are uncomfortably high. The challenge in many areas of vascular surgery and vascular disease are how to find this right balance of open, endo, and hybrid. And ideally, folks are coming out of training well-trained in both to have the perspective, the incentive, and the skill to be able to tailor treatment to the individual patient. I'm going to take you back to 2003. This is a paper I wrote as a fellow looking at high-risk characteristics. We wanted to see how they did in an era when EVAR was just getting a foothold. We looked at almost 600 consecutive repairs at the Brigham from 1990 to 2000, 80% of which were considered low risk. High risk was one of these criteria. What did we find? Well, overall, we had 6 deaths with 1% mortality, 0 deaths in the low risk group. All the deaths were in the high risk group. So bear that in mind. EVAR basics. I think everyone knows this. Baseline aortic anatomy is a key determinant of EVAR appropriateness and long-term clinical success. These are the anatomic criteria that we want, so-called ideal, and these are the ones that are outside of the IFU, and we do know that when we deviate from the ideal, the chances of failure go up. One of my former fellows, Andy Schanzer, stirred the pot a little bit with this somewhat provocative paper in 2011, looked at the predictors of sac enlargement in the M2S data set, and he found that if you use a liberal IFU definition, 30% of treated patients did not meet the aortic neck criteria. However, if you used a strict definition, 60% didn't meet it. 41% sac enlargement in 5 years, and in 30% of these folks, it wasn't detected until more than 3 years postoperatively. This is a paper out of Pittsburgh looking at the morbidity and mortality of open conversion after EVAR, and you can see it's considerable, 18% mortality. This is a meta-analysis looking at all the major randomized controlled trials for EVAR and also a number of case control studies, and 1 in 5 patients needed a secondary intervention at 4 years for a mean of 20%. I think everyone knows the NICE guidelines and the controversy around them. They were finally published after a lot of deliberation earlier this year, and they concluded, as we know, that routine EVAR was not cost effective and therefore would not be supported in England to the degree that many people would desire. This is a patient that I saw 2 weeks ago. In 2016, he was 78, he had 6 centimeter AAA and he underwent an EVAR in an outside facility. In 2018, he had an endo leak and continued expansion, and he underwent a right iliac limb extension and coil embolization of his hypogastric. Didn't quite do the trick. In 2019, he had continued expansion and more coil embolization, this from the translumbar approach. And in 2020, about 3 weeks ago, he presented with 10 days of back pain. He was on apixaban, which made things a little bit exciting, I sat on them somewhat nervously overnight, even with the CT scan that showed some stranding and an aneurysm that had grown to 8.2. This was an intraoperative finding, and he had a type 3 endoleak. Fortunately, did well with a modified repair. A couple of important papers have come out in the last couple of years I wanted to just call your attention to. This is one from the VSG&E. The aneurysm sac expansion is independently associated with late mortality, and basically a sac diameter increase of at least 5 millimeters at a year was independently associated with late mortality regardless of the presence or absence of an endoleak. This is another VQI study, V. Patel, looking at failure to regress. Almost 15,000 patients in the VQI, only 49% had one-year imaging studies, so somewhat sobering. 40% regressed, 35% were stable, and 25% expanded. And not only sac expansion, but any failure to regress was associated with higher long-term mortality. And this was independent of any reintervention or endoleak. And this is another nice study from Phil Goodney, again from the VQI, almost 13,000 patients, and they found a reintervention rate of 10 years of 33%. If there were high risk factors such as prior surgery or emergency surgery, it was as high as 72%. And again, cumulative incidence of reintervention of 33%, and cumulative incidence of all-cause mortality of 70%. Importantly, no evidence of plateau effect, and patients who had a reintervention had a 10-year late rupture risk of 20%. So to summarize, current status in the EVO world filled with persistent endoleaks, expanding or static sac size, poor compliance with recommended surveillance protocols, frequent reinterventions, late ruptures. I would argue that the literature overemphasizes how to managing the so-called challenging neck as open skills fade, and less needed time talking about the resulting gap between technical success and clinical effectiveness. And to conclude, unlike open, EVAR is not a cure. Off-label use should be discouraged. Timely conversion should be considered. And in younger, more fit patients, strong consideration should be given to primary open repair. Thanks very much.